Hello, good afternoon, folks. My name is Sarah Rahim, and I'm a program manager at Interfaith America. Thank you so much for joining us for today's conversation titled Mending What is Broken, Spiritual Caregiving and the Health Crisis. Today's conversation is co-hosted by Interfaith America and in partnership with Chaplaincy Innovation Lab. Before we get started, I'll call out a few things for this webinar conversation. So on the bottom of your screen, you should see a Q&A feature. That is going to be available at all times over the course of the next hour. And it's a space for you to post questions to the panelists as you hear our conversation. So I just want to call out, because we have a lot of folks joining this call, if you post a question for our panelists in the chat box, it may get lost. So please just keep the Q&A feature in mind, which we'll be referencing towards the end of this call. So I'm very pleased to pass it over to Michael Skaggs, Director of Programs at Chaplaincy Innovation Lab. So over to you, Michael.
Thank you very much, Sarah. I'm so pleased that we are all here together. And it's been wonderful to partner with Interfaith America. This is a new partnership over the past few months, but as we've had conversation and talked about the various things that we can do and pursue together, it seems more and more natural. And so I'm really glad to have Interfaith America as partners on this webinar and future work together. My colleague Suzanne will say a bit more about Interfaith America here in a few moments. But for those of you who are joining from sort of the Interfaith America audience rather than the Chaplaincy Innovation Lab audience, I do want to encourage you to visit chaplaincyinnovation.org, see the things that we have to offer, the research and the writing that we're doing on the state of spiritual care today and in the future. We look forward to a future where everyone who wants it has access to spiritual care. That's that's a tall order, but we're working very hard every day towards that. So today we have a wonderful panel that's going to discuss this combination of the human spirit and healthcare and physical health, and how treating all of this as a holistic approach to health and wellness is something that is not only a right, but something with enormous benefits that once it is explored, it really should be obvious how much tending to spiritual care should be part of healthcare, and what can positively flow from that. I'm going to introduce our guests very briefly, and then we'll keep going. So Dr. Anu Gorukanti is co-founder of Introspective Spaces. She is a public health practitioner, a pediatric hospitalist, and co-founder of Introspective Spaces, a social venture committed to building reflective space and community for women in healthcare, also a member of Sacred Journeys and Witness Fellowships. Professor Hadia Mubarak is Assistant Professor of Religion at Queen's University of Charlotte. She previously served as an Assistant Professor of Religious Studies at Guilford College and a Research Fellow at New York University, Abu Dhabi, and she is currently a Scholar in Residence with the Muslim Community Center of Charlotte. She has a much longer resume, including a number of fascinating publications, so please do go check that out. And then finally, Reverend Mary Martha Teal is the Director of Clinical Pastoral Education at Hebrew Senior Life. She has educated healthcare practitioners in the spiritual generalist model, which we will discuss, for more than 25 years. She's also one of the Chaplaincy Innovation Lab's longest standing advisors and supporters and all-around friend. So I'm really grateful that Mary Martha can join us. Suzanne, we'll turn to you.
Great. So good to be with you all this afternoon. There I am. All righty. I join Sarah and Michael in welcoming you to this call. I'm Suzanne Watts-Henderson, and I'm Senior Director for Faith and Health at Interfaith America. It's really nice to be with those of you who are part of the Interfaith America network, as well as those who are part of the Chaplaincy Innovation Lab network. As Michael signaled, it's been a really wonderful partnership, I would say even friendship, as we've come to know one another's work and seen the real synergy between our mutual vision for the positive and proactive, fruitful engagement of religious and spiritual identities in health-related settings. Some of you know that Interfaith America is a national nonprofit, really the leading national nonprofit working to promote interfaith cooperation and understanding across our civic landscape. And we've been doing that especially on higher ed campuses over the last decade, but in recent years have expanded beyond that. And our faith and health sector still rooted in some higher ed curricular interventions, really is building contacts and a broad network with folks across the faith and health landscape nationally, with those who are committed, as those on our panel are today, to unlocking the positive potential of fruitfully engaging religious diversity in health spaces. So it is just my deep honor to hand the baton over to Mary Martha, who's going to provide an overview of this spiritual generalist model and some of her deep and rich experience about its impact in health settings. Thank you so much for being with us, Mary Martha. So glad to have you join us today.
Thank you. It's nice to be here. Good afternoon, everyone. So spiritual care potentially belongs to everyone on the interdisciplinary team. The professional board-certified chaplain is the spiritual specialist in this model, and the rest of the team are spiritual generalists. Each member of an interdisciplinary team has a specialty discipline: medicine, surgery, psychiatry, nursing, social work, nutrition, and so on, all of which are necessary for good patient care. The specialty is why a given member is on the team. They make assessments in their field and provide care in their specialty. Each member of the team is also a generalist in the other disciplines on the team, with enough familiarity of the disciplines to know when to make a referral to one of their colleagues to support the patient. The team functions well only if its members know when to call on their colleagues to support patients. Spiritual generalists come from their own specialty disciplines and know when to call on chaplains, the spiritual specialists. The spiritual specialist on the team is the board-certified chaplain, with expertise in assessing and responding to the religious and spiritual needs of patients, families, and even staff. We professional chaplains have graduate degrees in religious studies and at least 1,600 hours of clinical pastoral education, CPE, and board certification. We are generalists in the other disciplines on the team, and we learn enough to consult appropriately with our specialist colleagues. In my situation, most frequently with nursing, with social work, with psychiatry. Other members of the team can become skilled spiritual generalists through training with us spiritual specialists and learning how to do some spiritual generalist screening. There are a number of models of spiritual screening for spiritual generalists in the literature. Two of the best known are FICA and HOPE. FICA was started by Christina Puchalski at GWIS, George Washington University Institute for Spirituality and Health. And the acronym FICA is F for faith or religion, I for importance of faith or religion to the person, C for community supporting the person, and A, address in care. So the focus in this model is primarily on screening for faith or religion, from which the healthcare provider can then decide whether to bring in the spiritual care specialist. And that's apt to happen when spirituality is of high importance to the patient, if the patient has an area of distress there, and when religion or spirituality will have a significant role in how the patient makes their healthcare decisions. The HOPE model by Ananjara and Haidt at Brown has another acronym. The H is for hope, sources of hope and inspiration. O for organized religion. P for personal spirituality and practices. And E, effects on medical care and end-of-life issues. This spiritual generalist screening model, in addition to screening for religion, which FICA does, more specifically makes room for spirituality and sources of hope outside of religion. Given the growing proportion of non-religious people in this country, this is really very useful. Spirituality outside religion here involves meaningful connections to something greater than oneself, like family. Most people have something greater than oneself in family. Could also be nature, vocation, ethnicity, politics, country of origin, a community of fellow sufferers, and so on. And again, from the results of this HOPE screen, the healthcare professional can determine whether to bring in the spiritual care specialist. If there's spiritual distress, if the chaplain can assist the person in their personal practices in the hospital, or if the person's spirituality will be an important consideration in what kind of end-of-life decisions the person's making. Whether a person is secular or religious, or most likely grounded in resources of both kinds, the core human spiritual needs and dynamics are the same, just expressed in different ways. It's the spiritual care specialist who's fluent in identifying and working with religious and spiritual dynamics of many kinds. Training with spiritual care specialists can support our colleagues in becoming more effective spiritual generalists. Spiritual generalist training helps healthcare providers become more skilled at spiritual generalists. They are able to give more targeted referrals, and that leads to better patient and family care. One of the things I most love about doing this training is that healthcare professionals get in touch with their love of the disciplines again. They remember why they chose the discipline that they're in. And this helps with burnout and the exhaustion that many healthcare professionals experience today. One of my students some years back was a family practice physician, and she decided after doing some clinical pastoral education with me that she wanted to move into palliative care, and that was a decision that brought her great delight. A neurologist who was one of my students took his learning and reshaped the neurology residency program at his teaching hospital. He wanted to move away from the shame dynamic that's present in some medical training. I thought that was an incredibly creative use of his experience with us. And another example is a nurse who decided she wanted to become more than a spiritual generalist. She wanted to be a spiritual specialist. She went and did some more academic education and some more CPE and became a hospice chaplain and has really loved the rest of her career. So training with spiritual specialists helps healthcare providers understand more clearly what chaplains do, what our expertise is, and this leads to increased referrals and teamwork. Mutual understanding and appreciation are always good for teamwork, and that is good for patients and for caregivers. Some of the trends in training, there's a lot of momentum of healthcare professionals wanting training in being spiritual generalists. When I started doing this 25 years ago, we were able to do it in a block of 400 hours, the gold standard of clinical pastoral education. We recognize that that is not a replicable model. Many people do not have access to that kind of time. So we then did an 8-hour workshop, including actors and realistic enactments to help healthcare providers learn this information. And that worked well, although it was an expensive model. So then we moved and went to a hybrid model. And in Massachusetts, for healthcare centers, we did a hybrid spiritual generalist course. And now, co-sponsored by Chaplaincy Innovation Lab and Union Theological Seminary, we're doing a hybrid course in spiritual generalist with tracks for pediatrics, adult medicine, and geriatrics. Why is it so important to build interfaith competencies across health settings? Well, patients and staff find that the intensity of healthcare raises spiritual issues. In some ways, it's that simple. Spiritual issues are present in healthcare. Interfaith competencies at the generalist and spiritual and specialist levels provide language to explore those dynamics, and support people with person-centered care. Good training avoids conscious and unconscious proselytizing. Sometimes the staff who are most interested in providing spiritual care are not aware that they're centering their own faith or their own spiritual style in a way that's not comfortable for the patient and may not be appropriate for that patient. Interfaith competencies also allow for the work of meaning making to be done skillfully with both religious and non-religious persons. And interfaith competencies are part of culturally responsive care in today's very diverse healthcare contexts. Any kind of culturally responsive care requires intention, humility, and learning, education to provide care across difference. So training can help providers focus learning on the traditions that are most frequently served in their institution. Healthcare providers want this information and often don't come with it. When I teach in one-offs, I often ask my audience, what can you tell me about the religious demographics of this place where we are? What's the most prevalent spiritual or religious identification? Rarely do people have the answer to that. So there's interest, but there's not much knowledge until there's education. There are lots of ways that spiritual care generalists and specialists can increase their collaboration with each other. Clinical care, ethics cases, Schwartz rounds. Many hospitals now have these case-based interdisciplinary rounds. Teaching each other's students, that's a simple thing, but it helps create good generalists. And we've talked about a number of spiritual generalist courses. Some are in person, some are virtual. A model at GWISH, I think, is really worth lifting up. They have a multi-day course that requires that a generalist and a specialist come together to really build the collaboration into the learning itself. That's a really creative model. So I want to say that in good patient care, specialists need generalists and generalists need specialists. And this is as true in spiritual care as it is in other disciplines. Thanks. Back to you, Suzanne.
Thank you so much, Mary Martha, for a beautiful overview of the landscape of generalist care, and also some real practical suggestions about how-tos and some very personal, almost case studies of that highlight the benefit of this kind of training and this kind of commitment in health settings. I want to remind our audience to continue to use the Q&A option to submit your questions. We'll be having a robust exchange, we hope, after our next presenters conclude their part of the conversation. So it is now my joy to join Anu and Hadia for a conversation that really picks up where Mary Martha left off. Mary Martha alluded so beautifully to the benefits, not only for patients, but also for providers. Sarah, let's go ahead and get Hadia in on this screen as well. See, this is a conversation among the three of us. Thank you. Thank you. So Anu is the physician, and in this case, although Hadia wears many different hats, she was invited to this webinar because of her experience as a patient. But Anu, I would love to start with you. So you are a physician. You are someone who I know kind of has a background and interest in interfaith competency, and you have started a whole organization on the side around fostering kind of a spiritual identity in healthcare providing settings. But I would love for you just to share a little bit from your vantage point as someone who is kind of by default a generalist. What's been your experience in healthcare settings as someone who has this radar screen for religious diversity? And how has it affected your interactions with patients? How has it shaped your own experience as a health provider?
Awesome. Thank you so much, Suzanne. And please let me know if my internet cuts out, and I'll turn off my video. But It's an honor to be here, and I appreciate Mary Martha's overview of the generalist and specialist model, since that's something that was new to me just in having this conversation and preparing for this webinar. As a pediatrician and someone who works in both the NICU and the newborn nursery, I have been kind of privy to many really intense moments in the healthcare space. And throughout my medical training, even though I went to a Jesuit university, there was very little dedicated education that we had to really acknowledging the spiritual component to healthcare, whether it was our own spiritual dimensions as well as the ones that really belong to our patients. And as I progressed farther in my medical training, went through residency, was working in these major academic centers where I was witnessing a lot of really tragic things. I was realizing that a lot of families turn to their faith tradition as a source of solace or a way to make sense of things that are pretty unimaginable. And I felt pretty helpless in knowing where to begin with these conversations. I remember one experience when I was working in the NICU, the neonatal intensive care unit, and supporting a family who had had twins who were born very early. And one of the twins was born with an issue impacting their heart, and we knew that they wouldn't be able to live for very long. And the family was grappling with the decision as to whether or not they would need to withdraw care from this infant because they knew he wouldn't be able to breathe on his own. And in having those conversations, I noticed in myself a struggle with wanting to support this family more than with just medical knowledge, but having to kind of help them tap into what really matters to them as a family, helping them think through what is the quality of life for the kids that they have, how do they navigate all of these different aspects of who they are and their own cultural and spiritual values. And it was during the pandemic, and so access even to chaplaincy and interpretation services were really limited. And so we were trying to figure out, how do we make sure this family gets the support they need? And that's one example of very many that I had throughout my time in training and in my current work, where I wish that I had more skills and background and learning how to navigate those conversations. And my work outside of the clinical space with Introspective Spaces really comes from my own moral distress and being in these moments and learning over the last several years that moral distress is a form of spiritual injury that many healthcare workers witness, being in these spaces, feeling ill-equipped to have these conversations, or working in places where people don't have all the resources and supplies that they need to serve patients, or the staffing. And so all of these things remind me that like dedication and resources for spiritual care is necessary for healthcare workers to serve patients, as well as to allow for our own sustainability in healthcare.
I knew I'm sitting here listening to your story and realizing that you're basically saying that your impact as a physician is affected by the distress that you've experienced in these situations where you weren't equipped, right? And so even from a kind of a health system leadership or a kind of curricular design perspective, it's really to the patient's advantage that practitioners like yourself are equipped, that there's an investment in the ability to care for the whole person. I want to switch over to Hadia and invite her to share her story as a patient a couple summers ago. I'll just leave it at that, Hadia.
Yeah, good afternoon, everyone. And I hope you can hear me okay. But I had some Wi-Fi issues, and happy Ramadan to those who are observing Ramadan at this time. So on September 6, 2021, my son and I were in a serious car accident involving 5 vehicles on the interstate highway, which fractured 3 transverse processes of my lumbar spine and tore the ligaments on my left foot. After being hit by a car on my right, my vehicle had spun out of control and completely flipped over a few times. I couldn't count how many times before fortunately coming to a full stop. And I felt like I was given a second chance at life. I felt blessed to be alive. I still think about why God kept me alive, but I really felt like it was a second chance. And distraught by the confusion and trauma of what I had just experienced, I felt very vulnerable on that hospital bed as a patient at Atrium Medical Center here in Uptown Charlotte, where I spent 3 nights from Monday to Thursday afternoon. And over the next 24 hours, the first set of 24 hours, many hospital personnel walked into my room, from doctors and nurses to cage managers and cafeteria staff. And I will say that, although I am a professor by training and usually have no problem articulating, there's something that happened moments after a car accident that was as intense as mine, that makes one, you're processing the trauma of of what you just experienced, and obviously coping with the physical pain and coping with trying to figure out what's wrong, and also being in a very, very unfamiliar setting. For me as a patient, it was my first time, besides giving birth, that I had ever had to spend the night in a hospital. So one of the challenges I had was that people were barging into my room without any notice, leaving me to just scramble to try to find my scarf and put it on very quickly. And not only
Hadia, you frozen for us. Sorry about that. I know you were having Wi-Fi troubles. Right in the middle of your gripping story. So maybe turn off your video.
then I feel awkward and uncomfortable having to quickly, when I met Ellis, a nurse who had specialized in a concentration, that I hope you can still hear me. Should I turn off my?
No, you're good now, but we missed kind of the key point. You were talking about how under duress you were as people were entering the room, and then you froze. So maybe rewind to there.
Okay, so what I was saying was that, people were barging in. Sometimes I was even asleep, or a male staff member. And not only obviously did I feel awkward and uncomfortable of having to cover my hair right in front of the male attending physician, but I also felt like my privacy as a Muslim female was not being respected. And so when I met Ellis, a nurse who had specialized in a concentration that intersected health and religion at a university in Miami, it was really a game changer for me. She put up a piece of paper on my door, and from then on, folks knocked on the door before entering just to give me a few seconds to put on my hijab. And I never found out exactly what she wrote, but I will say it made a tremendous difference in my hospital experience. And I will say that hijab is not just a cultural or traditional practice. More importantly, for Muslim women who observe the hijab, it is a sign of their devotion and submission to God. It is the manifestation of the very term Muslim, which means one who submits to God. So Muslim women observe the hijab only in front of men who are not close relatives. So as you can imagine, in that hospital for 3 nights, I don't want to have my hijab on all the time, right? It can be just very inconvenient and uncomfortable. So any moment a woman has to opportunity to take off her hijab, she will. But that could only happen, obviously, if she's given the privacy that of knowing, or comfort of knowing, that a male will not just barge in, that she will have a few seconds to at least put on her hijab. Also, another way that Ellis helped me was just by indicating what foods I could eat. And on some sort of portal she filled out, and the Atrium Medical Hospital where I stayed did not have a halal food option. So her religious literacy as a nurse allowed her to make selections for me that she knew could work, indicating that I could have seafood, that I could have kosher food, which really gave me a better selection of meals than just a vegetarian option that someone had selected for me previously. And so what I want to end by saying that, when Ellis showed concern for my religious values and practices, I felt fully seen and understood for the first time in that lonely and vulnerable hospital bed. I felt seen not only as a patient, but as a full human being with a spiritual and religious commitment. Thank you.
Thank you so much. I'm seeing posts in the chat about, what a moving story. I think when I first heard that story, Hadia, I thought, gosh, it's not that complicated, actually. Just what a difference that sign on the door made. Really, what a difference having a nurse who came in with enough religious literacy to ask questions and to engage you authentically. What a difference it made, and probably allowed you to really begin healing on some level. Anu, I want to return to you. You've heard now a patient side of a healthcare exchange setting. And I wonder if there's if you had words of insight or wisdom or encouragement for our audience, I wonder what they might be.
Yeah, thank you so much, Suzanne. And Hadia, thank you again for sharing your story. I feel like, even though this is the second time I've heard it, I find it very humbling, and it's such a good reminder of how these, like, the opportunity to, like, really listen and see these things for our patients can make such a big difference in really changing their experience in a hospitalization. And I think your story also really highlights how necessary it is to have this space in healthcare settings for both healthcare workers and patients to really acknowledge that we're human, that we come into our healthcare role with not just our professional identity, but also our religious and cultural backgrounds. And like Mary Martha was sharing in the trainings that were offered prior to allowing people to engage in their spiritual care, over time, the time allotted for that to happen has slowly been dwindling, from allowing for longer multi-day trainings to not even being able to squeeze in an 8-hour training. And I think that's really reflective of what healthcare in today's age really prioritizes, with its roots in capitalism and productivity. And that part of our work in reimagining healthcare is really thinking about how do we bring that spiritual component back to the forefront. And it's the only way we can really address the moral distress that both healthcare providers face and working in the healthcare setting. And that will allow us to more authentically provide human, compassionate care for the patients that we serve.
Yeah, and I'll just add, something that experience brought to my mind that I had never really reflected on was how much more difficult it must be for people who don't have the language to articulate what their needs are, or let's say their language barriers, or they're immigrants, and just layers of people who, for whatever reason, don't have the resources to be able to articulate what their needs are. And the other point I wanted to mention was, it's especially in those settings that faith comes into play. We don't think about it, but it's especially in those settings where, like I said, I felt like I nearly had a taste of death for a moment, and it's at those moments that I want to show gratitude to God, and I want to uplift my spiritual identity during moments that you feel vulnerable as a person, as a human being. And that's just something I wanted to.
Thank you. That was so beautifully put. And it takes me back to Mary Martha's comment about how the intensity of healthcare just raises spiritual issues, right? Regardless of one's participation in a particular tradition or not, it just raises these deeper, these currents of human questions about body and life and death and spirit and all that. So you all have brought the point of this conversation just so beautifully to light. And I really, really appreciate your time and your sharing of your stories. I hear you both saying, we're on a journey. Hadia, you've signaled that the interfaith competency it's not a standard in the health system that you were a patient in, but you came across one person who really made a difference for you. And I hear you speaking to the lack of kind of deliberate effort to inculcate practitioners in this way. I imagine there are folks on the call who will be in positions of influence, be it in their design of things like the shorts rounds that Mary Martha mentioned, or other trainings, or even systems within healthcare. And I wonder if there were one piece of this story that you would want folks to take away and take into their own particular health setting. Can you name what that might be, Anu and Hadia? And then maybe we can bring back Mary Martha and get her to weigh in on that question as well. What would be a takeaway?
Hadia, feel free if you'd like to go first.
Please go ahead.
Oh, sure. I mean, I think for me, I went into medicine because I felt like it was my vocation, the way in which I wanted to live out my spiritual practice. And I think one of the most jarring things of being a healthcare worker is recognizing that we can't always live out our values because of the way healthcare is structured. And I do feel like honoring the spiritual and humanity component of healthcare is the only way we can revolutionize the way that healthcare is administered in the US. And part of that means actually acknowledging and giving time for things that don't generate revenue, which is spiritual care, and kind of recognizing how valuable that is. And that all of us who work in healthcare went into it with this deep desire for us to be able to embody the values that come from our cultural and religious background. And we can only do that with time, with appropriate staffing, with all of the resources that we need to provide that kind of care. And of that includes making sure that we have chaplains, that we have diverse teams, that we support pipeline programs to make sure that our healthcare workforce reflects the patients that we serve. All those things are so deeply intertwined in having an anti-racist, anti-capitalist healthcare system. And that's what I hope for all of us, because someday we'll all be patients, and God willing, we have good experiences in the healthcare system. But even from my own patient experience, I know how necessary it is for the healthcare workers who serve us to be able to tap into their own humanity, which can only be done if we honor that in every level of the system.
I'm sitting here, the word that I'm thinking about with respect to your comments, I know, is radical. These are radical. This is a radical call, but radical really means taking us back to our roots. Healthcare grows out of spiritually inspired and delivered care. So thank you for calling us back to our roots. Hadia?
Yeah, I mean, I will just say, for those who are healthcare providers, I think there's a real need to be attentive to, obviously, I don't envy, the position of a physician or a nurse. My father is a retired cardiologist, and there was a reason I did not go into medicine, because I just know how stressful it can be. At the same time, because you're dealing with so many things, and like you said, Dr. Anu, I can really sympathize, or let me say empathize with, what you all deal with in terms of you literally have the life of this person in your hands, that you're trying to do everything you can to provide the best quality care, but don't really have the time to kind of process all the emotions that come with that. And especially you're dealing with death and dying issues as well, oftentimes. So having said that, I do think that there is a need for healthcare providers just to be more attentive to the spiritual and religious commitments of their patients, because, as I mentioned, it's in those health settings that I think patients really want to hold on to those values. I find, I mean, I think obviously it depends on each individual, but especially with cases of death and dying, I've experience having seen, relatives in those situations, and it's when they want to maintain their, if they're Muslim, their 5 prayers. They want to be able to find a way to perform I don't want to go on for too long, but certain ritual practices that are fundamental to their religious beliefs. And I think when physicians have to make decisions that would impede a patient's ability to uphold those practices, like intubate a patient or not to intubate a patient, right? I think those decisions should be made obviously based on what's medically best for the patient, but also in consideration of what will allow the patient to fulfill what's very valuable to them and meaningful to them. Again, looking at the patient holistically.
Thank you, Hadia. Mary Martha, you've kind of been listening in the wings, and I wonder if there's anything that you've heard that resonates with you, or just that anything you'd like to lift up as a takeaway.
Sure. Well, I love the story of Alice, who was a nurse who really put her values into practice, and she came with some knowledge. But it's also true that there are times when, as a healthcare provider, you won't have that information ahead of time. And something as simple as, how can I support your practices while you're here, can really help. So a nurse who didn't understand about halal food could simply ask that question and help you, how do you get that food. So it takes humility, and it takes learning to do this well. In terms of the end of life conversations, this is a place where often chaplains do get involved in family meetings and so on to make sure that everyone understands what's being said and that there's room for the religious and spiritual considerations of the family so that decisions will be made that feel right in people's souls.
Thank you so much. I think we're going to turn now to questions that have been posed by the audience. We've had a wonderful response in the chat. Michael, why don't you come on out and field these questions? I think you've been monitoring them.
Sure. Thank you very much. And thank you all for just a wonderful conversation and openness and candidness of your experiences. Many positive words in the chat about how timely and important this conversation is. So thank you. I do see 2 hands being held up in the participant list. So if you could just put your questions in the text in the Q&A function, that's a little bit easier to sort of manage that way. So if you could do that, that would be great. Jennifer asks a good question here about terminology, and I think this might help both physicians and chaplains talk about this in a way that makes the most sense. Jennifer says, is the term generalist accepted and used by other disciplines? So, is this sort of normal practice, I guess, and that's for anybody.
Hi, Michael. Do you mind repeating the question for me?
Is the term generalist common across disciplines? So if folks want to talk about this with others, is that something that's going to resonate as a term, or do they need to do some more explanation to lead up to that?
At least I can speak from the physician perspective. It wasn't a term that I knew until I met Mary Martha and learned a little bit more about the background of the generalist specialist model. But I do think the concept of generalists and specialists does exist within the healthcare space. So I think it's the same idea that applies to the spiritual care perspective. But I do think would need some context building if it were to be used in conversation.
So I first came into this term in a 2004 article in Southern Medical Journal by George Hanzo. And I'm sorry, I'm forgetting the second author at the moment. And they really played out this model, this metaphor of specialist and generalist in spiritual care. And it's one that has taken good hold in the spiritual care world.
Following up on that, Chelsea has a really good question about, I'm going to expand on it a little bit and say, if we introduce this model, you could see sort of enthusiasm begin to take over and maybe some mission creep from various people. So Chelsea's question is, how do we make sure that we and others stay within their scope of practice? When I think of generalist, I think of someone that can sort of answer questions in that area, but that's not something I can do as a chaplain when it comes to medical needs. I worry about the possibility of another provider overstepping and attempting to provide the spiritual support and knowledge that could be harmful or based on their own background instead of meeting the patient where they are. So how do we open the conversation, but also say, and here's the line where you need to make a referral?
That's part of what good training is about, good spiritual generalist training. So we really do want to make sure that people are not centering their own religious experience and spiritual style and imposing that on other people. So I think good training helps healthcare providers know when they are within their scope and when they should refer to a chaplain, to a spiritual care specialist. And that's exactly what we're there for. But there is a lot of good generalist spiritual care that can change the experience that patients and families are having in the hospital. And that's quite legitimate.
And then the only thing I'll add, Michael, is I just think approaching it with humility is probably the most important core component, and kind of recognizing that all of us have, even in our own domains, have deficits of our own knowledge and understanding. And especially when we're learning and trying to support in a domain that's different than the one that we trained, kind of recognizing that we don't come in with all the expertise and are constantly checking in with ourselves to make sure, like, is this something that I feel comfortable navigating, and am I bringing in my own perspective? And as someone who personally has been the recipient of many conversion attempts, even in the healthcare space, I think having that sense of humility is important and appreciated.
Sandos asks specifically to Hadia, how can we also empower Muslim patients to feel comfortable asking for accommodations when admitted to the hospital?
I think that's a really important question, Sundus, and I know she probably she is a chaplain. She is a Muslim chaplain at the hospital, so she probably has some advice herself. But I will say that my experience taught me that when you are a patient in a hospital, that's the last thing you're expecting. You know, we don't really plan to be in the hospital, right? Usually when we're in the hospital, there's some emergency that has happened. And because of that, there's this mental and emotional element of being distraught, just being really distraught and being confused. And I mean, as I mentioned, my car flipped over. And for me, like that metaphorically was like, I just felt disoriented. I felt really disoriented in a emotional, mental way as well, you know, in the hospital. And so it was like surprising to me that it took me that long to even be able to articulate what I needed. And I think it could be helpful. And also for us, many of us who it's the first time we're in a hospital bed, knowing what we can ask for, what's, you know, this was 2021. So it was a very, very busy time because of COVID. And you don't want to, you know, you don't want to ask for too much. You don't want to be that overburdening patient. You want the nurses to, you know, to like you. And so I think that also the burden should come from the hospital staff as well. That maybe there can be a sort of screening that in the beginning say, should we be aware of any religious accommodations or needs that you need during your stay here? Because that would alert the patient, like I have a space to now mention that I need X, Y, or Z. And I noticed someone in the chat saying emotional disorientation. Yeah, I don't have the words to express what was happening to me. I think some of you on the chat who have a mental health background probably have that language, right? All I know is that it really took me a while to realize that, hey, you know, I can say, and it really took Ellis, my nurse, who was just attentive to my needs. So I would concur with what Mary Martha mentioned, that, you know, there are some very simple things, strategies that I think healthcare providers can incorporate.
Barbara has a question that I'm going to consider sort of a follow-up to that. You mentioned creating this space by incorporating a question or something along the way. Do you have any particular needs that you'd like for us to know about? And Barbara's question says, it was mentioned attending to those who don't have the resources to properly articulate their own religious or spiritual needs. How can we do that as chaplains? So maybe the question is asked and the person, you know, for whatever reason, can't articulate at the moment what they actually need. Of course, a chaplain's job is not to come in and say, well, you need this. But if we think about the entire care encounter, making sure that even folks who don't exactly know how to articulate it have those needs at least addressed, if not totally met.
So this is really a great spiritual care question. And I would say there's no single answer to it. But some really kind, calm, open-hearted, open questions may help the patient and the chaplain get clearer about what might be needed. So, so what's important to you at this time? Where do you look for comfort when times are hard? Where do you find your inner calm? Those questions might elicit some information that would allow the chaplain to set up some parameters that would be helpful to the patient. But there's no one answer when there's that lack of clarity. But attentiveness and calm and a real desire to know the world of the person that you're meeting, I think often opens a door.
There was a question, and I'm sorry, I don't see it in front of me right now, but it's a really good one, and I'm sure that both Anu and Mary Martha can understand. It's a very old question for lots of chaplains, but the question was, many chaplains see themselves as part of the care team, and many others don't see the chaplain as part of the care team. So how do we reconcile this, and how can we address this in a productive way in an institution?
One of the things that I did to address that question 25 years ago was create spiritual generalist training. So actually, the very first Schwartz Center program ever funded was for healthcare providers to do CPE at Mass General, which is where I was. And one of the outcomes of all that was that I understood the stresses and strains of healthcare providers much better than I did before. They understood the expertise of chaplains much better, and consequently, referral rates went up and so on. Sometimes chaplains are worried, oh, if we train other healthcare professionals, we will be trained out of jobs. It's just been my experience that the reverse is true, that there's greater value put on chaplains, better understanding of what we can offer. And so it's really a win-win for everyone.
And I think to echo Mary Martha's sentiment, I think just having opportunities to build authentic relationships amongst different disciplines in the healthcare system is also one of the ways. And with our work with Introspective Spaces, my co-founder is a nurse. And I think for us having an interdisciplinary interfaith friendship over the last decade has really helped me understand, oh, that many of the challenges that we face are really similar, but we never have opportunities in our day-to-day healthcare space to just sit down and get to know each other as people. And I think having those opportunities in the healthcare setting, in trainings like the ones that Mary Martha has offered in the past, kind of allowing us to see each other outside of just our healthcare role, helps us to have those conversations to understand what are the different perspectives and values that each of us bring to the team, and also to kind of shift the healthcare model from being super individualistic and hierarchical to one that recognizes that every person on the team contributes to providing holistic care.
Akif has a really interesting question, and we sort of touched on this just barely, but this is a good moment to go into a little bit further. We've talked about sort of a universal need, a universal spiritual need, whether folks articulate that or not. But if we think about, okay, we have a well-trained care team, this institution is great about having generalists and specialists, but what about the patient that you offer any of this to and they say, I'm not religious, no thank you? I think this goes back to articulating need. So overcoming, maybe overcoming is not the right word, but addressing, well, that's not necessarily what we're here for. How do we serve those who would describe themselves as not religious, not spiritual? And Mary Martha, I think you're probably very well positioned to address this.
So if someone greets me with, oh, I'm not religious, I might say, well, that's perfectly fine. Tell me what's important to you. Tell me what might help you get through this time. And we start from there. And as long as I, as the chaplain, am not in any way defensive about their not being religious, the door's open. And I have actually never had someone in the end finally close the door around me in that kind of setting. Just lead with warmth, lead with acceptance, lead with curiosity, and it tends to go fine.
And I think the only thing I'll echo is with my work and with Introspective Spaces, even introducing spirituality to fellow healthcare workers can sometimes be met with a lot of skepticism and confusion or just a general disinterest. And I think part of that is kind of naming that people sometimes have religious trauma that has influenced how they like what their relationship to religion is, and also kind of offering a broader definition of spirituality. And for our group, like we talk about anything that connects you to something bigger than yourself. And so I think for us, kind of leading with that idea and kind of encouraging people to bring in, whether it's their culture, it can be an organized religion, it can be a set of values, and allowing people to lead with that rather than feeling like they have to prescribe to like a specific denomination of something. That sometimes helps us have that entry point for when people are like, I'm not religious, I don't want to even have this conversation.
Yeah, I'll just add one thing to this, which is connected to I think open communication is key. It's connected to a question I answered online. I don't know if you can see the response, but it is also connected to Atif's question. I just think it's really important for us to be aware of our biases and to put them aside and deal with each person as an individual. So obviously there is no monolith of a Muslim woman. Every Muslim woman is different. And despite the fact that we're in 2024, a lot of misconceptions unfortunately persist. And I imagine, especially about Muslim women, I imagine that they creep into the healthcare system as well. So I would say, put the biases aside, the biases that might make you think the woman is not comfortable speaking to you as a male physician or not comfortable being seen by a male. Those presumptions might be very incorrect and inaccurate. So I think open communication in general is key.
And I would say that part of being able to do that, what Hadia is talking about, is getting to know oneself well enough to know what those biases are. And that's part of what happens in good clinical pastoral education. One becomes aware of what one's biases are, because we don't start out necessarily knowing.
I want to give one completely unplanned plug for upcoming course through the Chaplaincy Innovation Lab. Mary Martha and another colleague are offering. It's called Spiritual Care for the Non-Religious. It's on a Friday and a Saturday. You can do it remotely. Check it out at chaplaincyinnovation.org, the events section. That was not planned, but since the question was asked, I think everyone should at least know about that. And you can go into a great deal of depth about this exact topic. So thank you for mentioning that. Suzanne, I see you popped up above here, so I'll turn it to you.
Wow, I'm just kind of blown away. I'm sitting here absorbing or trying to all the wisdom in the room. Who knew there could be such wisdom in a screen time together? So I just want to begin as we draw our time together to a close with a huge word of thanks to Michael and the Chaplaincy Innovation Lab folks, to my team, Sarah and Zia, who've been working to keep this all running, and especially to our panelists, to Mary Martha and Anu and Hadia. You have really grappled with some deep questions, and you've been vulnerable in your time together. You've shared your wisdom, and you've inspired us all. As a way of closing, we have a few calls to action. Michael's already offered one, and I think Zia, you can put up we got fancy and got a couple of QR codes. Get your phones ready. 2 opportunities. So this QR code will take you to a LinkedIn group that Interfaith America is hosting. It's very small because it's brand new. You could be on the cutting edge. If you want to find your peers, and these will be folks from across the faith and health landscape, broadly understood and broadly defined, we're going to try to use this LinkedIn group to keep each other apprised of opportunities such as the one that Michael just mentioned. In fact, there was a posting for this event, was our very first posting on that group. So please join us and stay in touch. And then the next slide links to the page on the Chaplaincy Innovation Lab where you can learn about the spiritual generalist training. Many of the questions in the chat had to do with how do we bring leadership along. Well, you are the ambassadors. You are the folks who can share the stories and can build consensus. And to the degree that Michael and his team or our team can help you do that, please do not hesitate to reach out to us. We want to be your partners in this important work. It's really life-changing and sometimes life-saving. So with that, I want to thank you for your time. And again, thank all of our participants who made today happen. Please, you'll get a recording of this session in your inbox soon. Feel free to share that with folks that you think might be interested. And as I said, don't hesitate to find us at interfaithamerica.org or at Michael's website, chaplaincyinnovation.org, and stay in touch. Thank you so much. Oh, and by the way, there will be 2 more webinars coming up this year. This is a 3-part series, so more on that soon. Thank you. Bye-bye.